So, the presence of diffuse ST segment elevation in anterior, lateral, and inferior leads should raise the suspicion of a diffuse myocardial injury like myocarditis. The troponin levels will definitely be elevated because the myocardium is getting damaged and it will release the cardiac biomarkers. Chest X-ray is going to show you signs of heart failure, that is curly B lines, as well as cardiomegaly, bilateral basal infiltrates, and the echocardiography will show that the inflamed myocardium is unable to contract. Inflamed myocardium, which finds it difficult to contract, will naturally appear hypokinetic or poorly contracted. At one point of time, the definitive diagnosis of myocarditis used to be achieved by biopsy of the myocardium. We used what is called the Dallas criteria for myocarditis to diagnose myocarditis, where a biopsy which shows both inflammatory cells and necrotic cells in the myocardial tissue. Now, since endomyocardial biopsy is a invasive and a procedure which has its own risks, we generally do not go for endomyocardial biopsy in most patients to make a diagnosis, but on the basis of clinical findings, that is usually a younger patient with fever, signs of heart failure, in an ECG showing diffuse ST elevation and cardiac biomarkers elevated, you should treat the patient as though you have myocarditis. So remember, not all patients of myocarditis requires a biopsy. We particularly do it if you have any suspicion of your diagnosis. If your diagnosis is in doubt, yes, you can go ahead and do an invasive biopsy, but generally we do not. We treat clinically on the basis of ECG and clinical findings. You can treat myocarditis. Now, why are we worried about myocarditis? One very clear thing about myocarditis is that myocarditis can cause death. Myocarditis causes death primarily because the inflamed myocardium does not contract, and that will produce contractile failure or pump failure, which you call heart failure. So, if your heart is not functioning, you will naturally develop other organ failures like your kidney, your oxygenation in the lungs, and that can lead to death. So, this would lead to really young patients sometimes dying of heart failure due to myocarditis. Another issue with myocarditis is the inflamed myocardium is also extremely irritable and the patient is at very high risk for arrhythmias. So, this is another thing that we should be prepared to deal with in your emergency arrhythmias. So, once you have the confirmed diagnosis of myocarditis, the, the management will be aimed primarily at managing heart failure. If there is edema, we would use diuretics. In case of hypotension, we might have to use vasopressors, nitrates. Long term, these patients need to be given anti remodeling agents like ACE inhibitors and beta blockers. Of course, once their BP is stable, you can give them this. As we will discuss later in our sessions on heart failure, remodeling is what produces worsening of the cardiac contractility in the long term. Many patients who have myocarditis in the long term progress to heart failure as well as dilated cardiomyopathies. In order to prevent this, we will have to give them ACE inhibitors and beta blockers and follow up these patients on a long term, even after the patient recovers from the acute attack. Arrhythmias are another very, very important condition that you should be very aware of. In these patients, if death happens, it's either due to heart failure or arrhythmias. You might have to admit these patients of myocarditis in the ICU, monitor them carefully over the next few days. You should also concentrate on treating the underlying cause. Okay, so in case it is an autoimmune condition like lupus or you're talking about sarcoidosis, you can give immunosuppressants. Antivirals can be used in certain viral infections like influenza. You can use oseltamivir, right? In case of drugs or toxins, you can try detoxifying these patients. The long term management of myocarditis is to understand that myocarditis can lead to heart failure later in life due to progression of the cardiac remodeling. In order to prevent cardiac remodeling, we need to start patients of myocarditis on anti remodeling agents like beta blockers, ACE inhibitors, and follow these patients up in the long term. To summarize, myocarditis is a condition that usually occurs in younger individuals who are likely to catch this inflammatory condition of the cardiac muscle due to infections, primarily viral infections. Especially remember in the COVID pandemic, this has been a major cause of death. So, usually a younger patient with a history of fever presenting to you with chest pain, signs of heart failure, you do an ECG, and if you see diffuse ST segment elevation, consider myocarditis to be a possibility. Elevation of troponin should not confuse you into thinking that this is ischemic heart disease, because ischemic heart disease is localized to a certain vascular territory like LAD or left circumflex or right coronary artery. Myocarditis, the ST elevation is spread all through the various coronary areas. So, diffuse ST segment elevation, telling you that there is diffuse damage of the myocardium, is the clearest sign that you're dealing with myocarditis. The diagnosis by using biopsy is not often needed. Echocardiography and chest x ray will correlate with your findings of myocarditis. Management of myocarditis important, short term as well as long term. Short term, you manage the patient in the ICU. Patient is admitted in the ICU, manage heart failure and arrhythmias. Remember, in the long term, these patients can progress to heart failure and cardiomyopathy. So they need to be monitored in the long term as well as treated with anti remodeling agents in the long term. Right? So that is completes our discussion on myocarditis. Thank you for listening to our cardiology lectures. To follow more of our topics, please subscribe on to our YouTube channel. You can also follow us on Facebook or Instagram for further updates. Thank you.